Welcome to the Jason Podcast. I'm Josie Briggs, Editor-in-Chief of the Journal of the American Society of Nephrology. Each month in this podcast, we talk about a topic that is reflected in one or more papers in the current issue. We always hope this discussion will prompt you, our listeners, to go to our website or turn to the latest issue that is now in your mailbox. Our topic today is data resources, transplant registries particularly, for studies of outcomes for kidney patients. The paper that prompts our conversation today is entitled Discrepant Outcomes Between National Kidney Transplant Data Registries in the U.S. Lead author is Kirsten King. Here with me to help unpack this study and some of the underlying issues is one of Jason's associate editors, Dr. John Gill. Dr. Gill is professor of medicine at the University of British Columbia and past president of the American Society of Transplantation. John has served Jason well for the last 5 or so years as our go-to person for clinical transplantation research. John, I'm very grateful for your hard work for Jason over the last 5 years, and thanks for joining me today.
My pleasure, Josie.
So it's an important topic, but before we get to this specific paper, I wanted to start with a general discussion of the data resources available for nephrology research. As journal editors, we often worry about the shortage of randomized trials in nephrology. One of the main conclusions of a systematic review done 5 years ago by Akam Anders and his team was that nephrology has fewer RCTs than other areas of medicine. Actually, I don't think that's changed much, and I don't want for 1 minute to minimize the issue. But I do think it's fair to say we have strong data resources for study of kidney disease, particularly for care delivered to people with failing kidneys. So I think, John, can I ask you to provide a quick rundown of the 3 transplant registries in this study? And let's talk about what their actual sources are for the data they report.
Sure, Josie. So I think I'll take a couple of minutes to give a bit of a history of the data system from the transplant perspective. So the Organ Procurement and Transplant Network was established by NOTA in 1984. And after that time, both the OPTN and SRTR contractors were really provided with the responsibility of providing national transplant data. And this includes data for patients who are on the waiting list, patients after transplantation, as well as organ donors, to a variety of interested users, including researchers and other entities. In addition to providing this public data, the OPTN and SRTR contractors have additional responsibilities. The one I want to highlight is that the SRTR is responsible for the performance evaluation, or what we often refer to as the regulatory side of things in the transplant world. This includes the program-specific reports that report on how each transplant center's outcomes are, as well as the OP-specific reports. So that OPTN data is really the primary source of all waitlist and transplant data, and they provide that data to the United States Renal Data System. So the main sources of transplant data for the USRDS are in fact from the primary source, which is the OPTN. So that was started in 1984. And the strength of the system is that there's a requirement for transplant centers to report outcomes into the system. And up until 1984, it's remarkable that all of that reporting was primarily from the transplant center. Now, of course, that has some limitations, as I'm sure we'll get into later, that, in the long term, transplant centers don't always directly follow their patients. So particularly for long-term post-transplant outcomes, this was a concern. So beginning in 2004, the OPTN started to receive data from the Social Security Death Master File. And just as the name implies, this is a comprehensive listing of all deaths in the United States compiled nationally by the Social Security Administration. And so that source was used to supplement particularly death data in the OPTN. Now, there's a period between 2004 and 2011 where this was, I think, very, very robust. But in 2011, there were restrictions that were posed on the use of death data in the Social Security Death Master File. And basically, without getting too much into the policies of it, the Social Security Administration agreed that individual states could pose restrictions on the outcomes of death that they had collected. So it's important to recognize that although we have a national system, death outcome data is really collected locally, and it's always been a decentralized process. And so states that wanted to restrict the access to that data and its uses in the Social Security Death Master File were allowed to do so. And this is not unique to transplant. This is unique to, this would affect any area of health outcome reporting where they were using this data. So at that time, about 4 million deaths were actually removed from the so-called public version of the Social Security Death Master File. And annually, about 1 million fewer deaths are estimated to not flow into those public files. Now, importantly for the listeners, this sounds very complicated, but we do still maintain the overall sort of fully or complete Social Security Death Master File. It's just that the deaths that come from states that wish to restrict access to their data have subsequent limitations on whether other users can report them. So in this particular case, OPTN receives the full Social Security Death Master File, but they're not allowed to report deaths that are from state records without independently verifying them. So only to give the readers a sense that we still have access to all these events, but the ones that can appear in the public files that are available to researchers have to go through this additional verification process.
I think it is startling to people to realize that access to information about death is often inaccessible. I was once part of a panel discussing use of electronic health record derived real world data for clinical trials. The NIH collaboratory that I was involved in started a number of years ago was very much encouraging that. And one of the panelists startled the audience by saying, when you're dealing with EHR data, death is not a hard outcome. A gap that arises with electronic health record derived information as well as this registry data. And of course, deaths don't occur necessarily in the facility, which has the primary patient's clinical record. Okay, so I interrupted you with that reminiscence, but keep going. How does this work in the real world? How are people able, what are the discrepancies that the authors of this study pointed out, and how does it influence the use of these resources?
Yeah, so important for the conversation is to remind everybody that a person in the OPTN data or in the USRDS data, for that matter, is assumed to be alive unless there is a death record. So that's an important thing. So there's an assumption that in the absence of a record that patient is still alive. And the reason there are differences in the data sets are related to the internal verification processes that are employed by OPTN, SRTR, and USRDS. So the death verification that the OPTN uses is, I can briefly summarize it, or try to briefly summarize it, in about 3 simple steps. Deaths that are reported from the transplant center don't require additional verification. They're counted as deaths in the OPTN system. For deaths that they obtain a record from the Social Security Death Master File, but they can't release unless they're verified, they do 3 steps. The first is, and this has historically been the case, there is CMS data that goes to the University of Michigan, and this is really cost center data that they use. So that's one verification step. They also have a massive data linkage process through a proprietary tool called Accurint, and it links to a huge database called LexisNexis. And I'm not going to go into the details of this, but importantly, they finally have a manual verification step where actually OPTN staff search manually for online sources, including obituary data, to verify deaths that come in the death master file. So beginning in 2013, the OPTN started this death verification process. And you can imagine, because it was so labor intensive, they limited it to the first 3 years after the transplant, and for people on the waiting list, including 1 year after waitlist removal. And that's because the simple feasibility of doing this. Now, importantly, in 2022, they decided to enhance that process. And the enhancement really was to say that they needed to outsource that manual component of the verification process. And many listeners are probably aware that at that time, 35,000 additional deaths were added to the public standard analysis files released by the SRTR and the OPTN after this so-called enhanced process, where a third-party vendor was given the task of doing this manual obituary source searching. So only to say in broad strokes that that's the OPTN process. There are some nuances in terms of what additional steps SRTR will do and additional steps that USRDS can do that OPTN cannot do. And briefly, what I'll highlight there is the USRDS obviously has information about people who return to dialysis after transplant failure. So if you're looking for information about deaths that occur after transplant failure, those will only be captured in the United States renal data system and won't necessarily be captured in the SRTR or the OPTN STAR files.
Thank you. I think the USRDS has these very strong connections with the Center for Medicare Services, which certainly results in a very high level of complete data about dialysis. I think one of the lessons I hope we're giving to our listeners is these are wonderful resources. They're available to qualified researchers, but you really have to know where the data comes from. Advice you'd give users of these resources?
Yeah, so I think that as you've pointed out, one of the real beauties of the system is we really, for chronic kidney disease, have this concept of a continuous data system. So which begins at the time that someone starts renal replacement therapy, whether that be a preemptive transplant or dialysis, and it continues to follow those patients, at least conceptually, through that transplant event, if that transplant fails, back onto dialysis, and then potentially even with a second or even a third transplant. The important thing about this is if you're using these resources, is to understand that there are slight differences. So for example, in the United States renal data system, they won't have information on mortality on preemptively waitlisted patients on the deceased donor waiting list, because their records start when someone gets renal replacement therapy. And similarly, as I've highlighted in the previous point, the OPTN data system won't have data on people after transplant failure back on dialysis. I think the most important thing for anybody using these data sources, or perhaps wanting to link to external data sources that may be maintained by private insurers or what have you, is to know what the data sources are, to understand the death verification processes that exist, and the definitions of how an event is or is not recorded. So is it an absence of a record, or if it is not, how is the death verified? I think these are the key points.
Right. And the gaps can be at the beginning or at the end, particularly. The strength of our data resources is worth reiterating. Can I ask you to comment on any comparisons you have between what we have in the US and other data systems?
Yeah, absolutely. I think the first thing is again, this concept of a continuous data system. So some countries, for example, we can use the UK as an example, they will have the dialysis registry, which isn't inherently linkable to the post-transplant outcome data system. And that exists in many Western European countries where you will not have this ability of a continuous data system. In Canada and the ANZ data system in Australia and New Zealand, there is this concept of a continuous data system for patients with kidney disease, which allows you to basically track patients across the continuum from dialysis to transplant and back again. So those are some important differences. Importantly, this issue of really where is death captured is not unique to the United States. If we think about it, historically, deaths have been a local governmental responsibility. So what happens at a state level or a province level might not get transmitted to a national level. Classic example of that in the Canadian data system is for a number of years, Quebec data has been excluded from the Canadian Organ Replacement Register. And so these variations are the reality of the fact that we have a very strong data system, but there are some limitations that get applied from regional governments, and they're ultimately the ones that are collecting the data, for example, with regards to death. So I think there are some differences. And again, as you commented earlier, Josie, it's really important for researchers to look at the support documents that are provided with the data set. The USRDS provides a very robust researcher's guide. And to know that the people at USRDS and SRTR and OPTN are there to help researchers. So there are resources to be able to understand and navigate some of these nuances.
Yeah, we live in a data-rich time, and many of our listeners are probably aware of resources in their own facilities. We've got very strong data resources being used at the Mayo Clinic, the PedsNet, PCORI-funded network. Kaiser system has excellent data resources. And sometimes the most insightful analyses will make use of registry data and electronic health record derived data. So it's a data-rich time, but it requires wisdom and knowledge to use it well. Well, John, thank you so much for your thoughts about this paper, and indeed for all the advice and guidance you've given to me as our JASON team go-to person for transplantation work. So thanks so much.
Thanks, Josie. Always great to chat.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.